Welcome back to Imperial College Healthcare NHS Trust, and we're very fortunate today to have Bushra Rana with us. She's one of the world leaders in echo, but we're not going to ask her about how to do an echo and how to interpret an echo. This section is about protection, and this is really about how to protect the operator in the midst of a COVID crisis. So Bushra, you've looked into this in depth and you're running our department. So in a few words, how have you changed the way you practice?
So first thing to say is it's a team approach. I've got several amazing colleagues with me who together we've come out with this plan. And the key has been that in terms of the type of tests we're doing, we've looked at the risks in terms of viral load and exposure to the operator. So in terms of transesophageal echo, it's classed really as an aerosol generating procedure. So from our perspective, we've actually put a hold on that test altogether, unless there's a very good reason. And then we have a checklist of how we ensure that there is a good reason before we proceed to something like that, because it would mean full PPE for the entire team. And when I say full PPE, I mean eye protection, I mean head and neck cover, I mean a full gown with your long arms protecting you, double gloves, and FFP3 mask. So TOE, really, we've done very little over this period. What we have done is focus on the transthoracic echo, and we've looked at both outpatient, inpatient scanning, and realized that a lot of the scanning can actually be put on and deferred till after this period is over. So we've only done urgent echoes, which really is a very small percentage. Probably 5% of our entire workload has been only done in this time. But what we have done is move to inpatient care. Now, in terms of inpatient care, we've looked at our categories of risk in terms of the infection risk to the operator, and we've categorized them, and you'll hear this through the other talks, I'm sure. Category 1, 2, and 3. Category 1 and 2, first being confirmed or suspected, and then 3 being likely, highly likely, or confirmed COVID negative. And confirmed COVID negative means you can do basic PPE, because we're not entirely sure of the risk, not only of the patient to the operator, but obviously the operator to the patient. So we wear surgical, when I say basic PPE, I've described what full PPE is, but basic PPE is a surgical mask or water resistant mask with an apron and gloves. And we are actually adding in eye protection for the operator too. So that's our basic protection within the lab.
Okay, fantastic. And so we're going to hear your talk about the details behind that. So have you, just to probe you just on the transesophageal echo question, has there been any indication in the last 4 weeks for doing a transesophageal echocardiogram?
The answer to that is simple, it's no. Because what we've done is we've moved to handheld cardiac ultrasound. So we're doing a BSc equivalent level 1 scan, which basically means 2D and color Doppler. And I think the advantage that how we've approached this is we've had clinicians, so consultants and registrars who are all BSc accredited, are going into inpatient settings and are performing these scans, which are basic and limited, but we're able to answer the clinical question. I think that's the key, and that's the power of echo in the hands of a clinician. So I think that's how we have managed not to do a single TOE in the 4 weeks.
I think that's a very safe process, and also you've managed to achieve what appeared to be unachievable 4 weeks ago, which is to upload these handheld echo images to our central packs so they can be recorded for posterity and reported properly. So in every crisis there is some light, and part of it is the rapid way that the IT has moved in this scenario. So Bushra, thank you very much for joining us.
You're welcome. Thank you very much.